Thank you, Ajay. It's always a pleasure to be here. I think my third consecutive year. Always happy. So over the next 30 minutes or so, I'll be dealing with the calcific nodules. Managing calcific coronary artery disease is challenging because the lesions are very complex. We know they have very high syntax score. There is left main ventricular vessel disease. Lesions are tight, angulated, and they are ostial in location. CTOs are not uncommon. Most importantly, these patients are elderly. They have multiple comorbidities, COPD, diabetes, CKD. It's not uncommon. And if you look at the lesion morphologies, calcific nodules and thick circumferential plates. Now, it's these morphologies which make the procedure even more complex. Now, if we look at calcific nodules in the subset of ACS, they account for about 5% of the patients presenting to us with acute coronary syndrome. That's probably because of thrombus formation over the surface, and they are associated with very poor outcomes. As you can see on the slides, the MACE rates are very high, and the other outcomes in terms of other long-term outcomes are equally bad. Cardiac death on a higher side, you have TLR rates on the higher side, and you have more stent thrombosis. So this is a very difficult subset. Before I launch myself into this, and if you see the slide, it tells you that the event rates in a lesion or a calcific bed where there is a nodule, the event rate is going to be 3 times higher. So I thought we'll just touch upon a little bit of pathology of the calcific nodule, and we'll see as to how it develops and how it comes into being. Now, it's generally seen in the proximal segments of all the large vessels. That means, as you can see on the slide, in the proximal or the mid part of the RCA, it commonly involves, mainly seen in the proximal LAD as well as in the proximal circumflex. Why this part? Because this is the portion where you have a larger necrotic core. This is the portion where you have a big gap between the intima and the media. So more plaque buildup can happen in these areas. Well, when we look at the evolution of the atheroma, I thought I'll just touch upon this part. It all starts with the deposition of ApoB, which binds to the proteoglycans, and this causes diffuse intimal thickening. The next thing which happens is the vasa vasorum start growing. They attract some monocytes coming in, mature into macrophages. These macrophages in turn internalize the lipoproteins and become the foam cells. And when they kind of rupture, and they are engaged in some constant activity of preventing atherosclerosis. That means there is TGF beta as well as interleukin which is coming in, which kind of takes away the apoptotic cells. But it's at times difficult for them to keep pace with the degenerative material which is being produced. And what happens is that there are some vesicles which are left behind which have not been taken up by these macrophages, where hydroxyapatite gets deposited, and that leads to microcalcification. As this microcalcification grows, it becomes macrocalcification. So in effect, what is happening, as you can see in this slide, it all starts with spotty calcium, which becomes an eggshell calcification, and there later it becomes hard shell calcific nodule. Now, why I'm telling you all this? Because this has got implications on what I'm going to tell you in my talk subsequently, because this is kind of what we used to read in anatomy. What I'm going to do now is applied anatomy. We are going to dwell upon on the basis of what I have told you. Well, as I told you, the calcific nodules develop in the proximal part of the vessel. These are the parts where there's a lot of torsional motion which is going on. So the necrotic core here builds up, and it's in between the calcific. Can I have a pointer? It's in between the two calcific plates that you get to see. Yeah. So these are the calcific plates, and in between them, there is a necrotic core built up with calcific plaques, and this core is now gradually calcifying, and at the hinge point it starts protruding, and the moment it protrudes, it breaks open into the lumen of the vessel, and you have a nodule formation which now breaks into the lumen. Now if I use the OCT images, this is the commonest type of plaque which you get to see, which is the superficial calcific plate, and this could be thin, thick, it could be segmental or circumferential. Now multiple of these plates, when they coalesce, they break open into the lumen of the vessel. When they break open, there is a little bit of thrombus which comes along with it, a fibrin which is there, and they have a very jagged surface, and this is what is called an eruptive nodule. This is a biologically active nodule. It accounts for 25% of the nodules of the calcific plates which we see, whereas a nodule which is just protruding from the media into the surface of the vessel is smooth, absolutely smooth. There is no jaggedness or irregularity over its surface. It accounts for about 7% of the total nodules seen. And this is biologically inert. It does nothing at all. So how do we evaluate? Now that we've seen that there is genesis of these nodules, how do we evaluate? Angiography is not good enough, but what you see on angiography could give an impression of a thrombus, But if you see something, the positive predictive value of angiography is about 94%. But many a times, I'll show you case examples, nothing is seen and you find a nodule which is there inside. So angiography cannot differentiate between eruptive and protrusive nodules. Well, we use imaging, but imaging except for the OCT, the IVUS is not going to tell you whether it's an eruptive or protruding nodule. So this was a case which we did last week, 9th of January. There was a distal disease in the RCA. So we thought a discrete lesion we'll get in, and you see what happened. The balloon, a small balloon also is not getting into the proximal part, which looks pretty okay. It doesn't look to have anything there. And when we did the OCT, there was a big protruding nodule which was lying just next to the wire. As you can see, the wire biased by the guiding catheter. And this was a protruding nodule which prevented. So these are nodules which are not visible, on angiogram. Well, the limitation of the IVUS and the OCT is that IVUS produces a kind of acoustic shadow, and beyond that you can see nothing. And unfortunately, even OCT produces a negative shadow. OCT otherwise in a calcific plaque goes around the vessel. It can give you the thickness of the plaque, but in a nodule, the segment is so thick that it also creates a kind of negative shadow, and you can see nothing beyond it. So the OCT is also not very helpful. There's one technology which has been found to be slightly useful in the imaging segment, which is near-red infraspectroscopy. Now, near-infrared spectroscopy is capable of telling you about the configuration of the plaque behind the calcium plate. So, which neither IVUS or OCT can tell you. Do we have an equipment to do or to study the same? Yes, we have the Makoto machine with us. This is a dual imaging catheter system which kind of gives you co-registered images of IVUS as well as NERS, so that you get to know the plaque morphology as well as the composition of the plaque. HD IVUS is going to tell you what is the structure, and the NERS is going to tell you what is the composition of this plaque. By composition, what I mean is that, I must give you the background. The NERS has been used transcranially in the past to measure the cerebral oxygen concentration. It has a very high sensitivity, specificity of picking up lipid. And this is an histological confirmation of that. The core localization of lipid histopathologically as well as on NERS, but it temporally does not localize whether this lipid is superficial or is deep. So they did about 2,500 cross sections of cadaveric coronary arteries, and they found 95% sensitivity, specificity of NERS to pick up the calcium, to pick up the lipid pools. Now, how it works is that you have the NERS signals which get into the vessel and they get reflected back, and they generate a kind of probability score between 0 to 1. A score of 1 gives it a bright yellow light. Anything closer to 1 makes it little oranges. And if it is close to 0, it makes it red. So this is a kind of a color-coded interpretation of the vessel wall composition, which is called the NERS chemogram. So red means no lipid, yellow means lipid. If you see a few black dots, they are being produced by the artifacts of the wires. Now it quantitates, it not only detects, it also quantitates on a scale of 0 to 1000. LCBI score of anything more than 400 is considered to be significant. You also localize the point where you get maximum LCBI, which is called max LCBI. Any max LCBI score of greater than 400 is considered to be significant. Well, you see this max LCBI score which comes automatically when you do the run. This implies that in this necrotic core, 82.4% is lipid. No, I must tell you here, since I'm not doing an ACS talk, it is lipid and only lipid which leads to thrombus formation. If you have a necrotic core which is devoid of lipid, you will have absolutely no slow flow or no reflow happening, or you will not have any kind of distal embolization which is leading to TIMI count flow less than 3. So it's only lipids which produce slow flow. Now, what has also been seen is that as your LCBI score goes up, the calcium in the vessel increases. So that means LCBI helps you determine plaques, or tells you about the plaques which are biologically active. And if you look at this forest plot, those with LCBI score of more than 250 had more calcium. That means these are biologically active plaques which are of advanced phenotype, and they'll lead to more calcium at a later date. How is it different? IVUS nurse, it's a dual imaging modality catheter which assesses the structure and composition. It has got a bigger imaging range than most of the existing systems. It images about 150 millimeters. It's got 3 variable pullback speeds of 0.5, 1, and 2. The lens moves bidirectionally. A click of button, the lens comes back to its original position so that you can do a pullback. You don't have to manually do anything. It's a very sturdy catheter with very good pushability, but most important is that it produces some amazing imaging pictures. So these are pictures which at times when I've gone around centers, people have said it looks like black and white OCT. Very nice images. The advantages, you have a co-registered nurse available which tells you about the plaque composition. It not only picks up the lipid but also quantifies it. And how does it help? It takes the prescription out of the lab to the OPD. If you're dealing with ACS, you know that the LCBI score is very high. You need to continue statins or add anything more to statins to get the scores down. And now this helps you predict, and there are a lot of studies, I'm not going into that. It basically helps you predict the MACE rate at a later date. That means those vessels with higher MACE score will have higher event rates, as was shown in the LRP and the Prospect 2 trial. The characterization of lipid behind the calcium, you'll see the applied anatomy of this in my subsequent talk, is basically helpful in selecting the tools which are required for dealing with the calcific lesions. Now, having talked about LCBI, let's come back to the calcific nodule and let's see as to how we go about managing these calcific nodules. There's a simple algorithm which I've made. If you have a suspicion of a calcific nodule on angiogram, the first thing you do is coronary imaging. So it's the intravascular imaging which is going to confirm the presence, and you kind of define what kind of nodule is this. Is this an eruptive nodule or a non-eruptive nodule? And your approach thereafter is going to be dictated by the type of nodule which you picked up. If it's an eruptive nodule, the first question is, can you deform this nodule? Or if you have the facilities of IVUS nurse, you'll apply IVUS nurse to look at as to the character of this nodule. I'll give you case examples. So if you cannot deform the nodule, you will have to rely on atherectomy tools plus minus IVL, and thereafter regressive dilatation has to be done. If you can deform, nothing else is required. It's a deformable eruptive nodule. You just do aggressive dilatation and stenting. But if you have a non-eruptive nodule, it's the orbital only which is going to help you. Road ablation is not going to help. I'll tell you the reasons why. Once you've dealt with the nodule, you have to ensure that you have an optimal stent expansion, and that is what is going to produce good results. But not all the patients you're going to do this. Certain patients who have only isolated nodules, CABG is an option, because the results of calcific nodules, I told you, is much worse than dealing with superficial calcium plates. So you must keep that option also open. Well, case examples of deformable nodule. This, as you can see, an angiogram with a shelf in the LAD, calcium nodule which was there. We did IVUS nurse for this, and what you see is circumference. This is a calcific plate with the acoustic dropout, and you can see circumferentially this has a large lipid pool behind. So this, on IVUS nurse, we could make out that there is a nodule, but this is at a stage where there is a lot of lipid pool here. We don't need any specialized atherectomy tools. This is a deformable nodule as defined on IVUS nurse. The nurse shows a lot of lipid here, and no wonder his score was very high. 816 was the max LCBI score. That means the lipid pool in this calcific so-called plaque or the nodule was to the tune of 81%. So we just dilated. Now, as I told you, it does not localize. So this lipid could have been within this plate or could have been behind the calcific protrusion. Nobody can know this for sure, but it definitely implies that this is a nodule which is deformable. So what is a deformable nodule? That means when you dilate these nodules, the wire remains in the center and it does not go to one side. And a non-deformable nodule, you'll see the wire hugging only one side, the balloon inflating only on one side. On the other side, it's not inflating at all. Correct? So this is a deformable nodule. This is a non-deformable nodule. Fine. So what we do is, and these things you have to keep in mind, we dilated this and you see the kind of slow flow. I was telling you, if you have high LCBI, you get slow flow. Now, it is very rare that you do a calcific lesion dilatation in a native coronary vessel and you get to see slow flow. So that's not very common. Now, this has been studied in a small study where they divided the patients into two pools. That means those with the small calcific plate and the large calcific plate. They noticed that the patients they are different cutoffs which they mention, but it's not uncommon to get slow flow in these patients. What is the reason for this? This probably could be distal embolization, redistribution, nobody knows. But if you have a high LCBI score, you should be prepared that there can be slow flow happening in these segments. Sorry. So we went ahead and stented, and this is the stented part. You see very good imaging qualities. The LCBI score has already come down to 260. This is a cartoon commensurately showing that a deformable nodule, which could be either of these two situations, it gets pushed and you get good MSAs in a deformable nodule. There's absolutely no problems in that. And this was the final angiogram of this patient, and it looked pretty good, both on imaging as well as on angiogram. Now let's look at some non-deformable nodules. Now atherectomy, as I told you, if it's non-deformable, atherectomy is of choice. Rotablation is suited for uncrossable lesions. So rota is the only front cutting device. So if you get into a situation where you cannot put anything across, it's rota which is going to bail you out because this is a front cutting device. But does rota work in nodules? Yes and no both. What it does is that it does need a suitable wire bias, but most importantly, it modifies the nodule very little. So that means there is always a need of having large size burrs with a suitable guide wire bias, a combination of these two. And most importantly, what is true even for all the atherectomies in nodules, your MLA at that segment has to be very small. I'll show you a little later on about that also. So you can combine now rota with the IVL and do, and how it works is this way. Rota shaves off the peak, and thereafter you use the shock. You're using shock, it's like a dynamite. You're going to now crack this calcium, and once you crack this calcium, everything settles down and you can go ahead and stent. So that's how your rotatripsy works in a nodular calcium. Shave it and then kind of shock it, and you get the desired results. And this is what we did in this case. We went ahead, you can see the nodule here, it was non-deformable. We did rotablation, post-rotablation, and now it was shown in the morning, and I show you my pictures. So this is a normal vessel, this is a suitable guide wire bias, and this is a eruptive nodule, and this is what is differential cutting. The normal vessel wall remains intact, and what rota does is a very small modification here. So rota, it depends on the size of the burr. So this is the kind of modification that you get, which is not sufficient for you to reduce the nodule. So this is probably a downside of the rota, but this is how it works. So it's a true front cutting tool for uncrossable lesions. We did IVL. There was a significant IVL waste to begin with, a little bit of air in the balloon, but thereafter on the fourth cycle, there was no waste. And we went ahead and stented. For paucity of time, I'll skip. This is post-IVL. This was the final LAD run. The nodule is kind of completely flattened. Well, longitudinal profile of the OCT, jutting nodule, and the nodule has been flattened post IVL. Now, how does intravascular lithotripsy work in a calcific milieu? Well, the advantages of IVL is that it works independent of wire bias. It modifies the nodule as well as the surrounding calcium, which is very, very important. It modifies both the superficial and deep calcium, and it kind of restores the vessel compliance, which is what leads to stent expansion. The outcomes which were noted in this current study was similar in patients with or without calcific nodules. So this is a big plus of IVL. That means it produces outcomes which are similar in patients having and those not having calcific nodules. Now, protrusive calcium is a different ballgame altogether. Neither ROTA or IVL are going to help you as an isolated device. You need something which debulks, and this is where the role of orbital atherectomy comes. This was the RCA, which was previously stented. There was a big nodule, again, one of the recent cases. This is the kind of nodule which was there. And this is the nodular segment. We'll come to that. It's kind of hugging. So nodule. Now this doesn't have jagged edges. It's got very smooth edges. So it's kind of jutting into the lumen of the vessel. So this is a protrusive nodule. And we did orbital atherectomy for this lesion. And this was stented. Now, you see the pictures as to how it happens. This is a calcific nodule. The areas are very small. The nodule post-ablation, correct? And this is nodule post-stenting. So you get good MSAs, you get good luminal gain. It debulks the nodule tremendously. If you're using orbital atherectomy, thereafter you don't need any specialized balloons. NC balloons are good enough and they will work very well. So orbital atherectomy is most suited for debulking. It is best for large vessels. You start at lower speeds, then go to larger speeds. But the requirement is that the MSAs have to be small. Because if the MSAs are large, the device is not going to work. You see from this paper, those with MLAs less than 2.5, the percentage reduction was nearly 40%. And those with the larger MLAs, the reduction was only about 17%. It stands to reason. If you have a very large vessel, we know that orbital as a tool rotates and orbits. If your orbit increases, your centrifugal forces come down because it works with the formula where radius is in the denominator. So if the radius increases, your force comes down tremendously, so your debulking will not be good. Now, in the ostial segments, we need to use a different protocol. There are a lot of ostial nodules which come. Now, for the ostial lesions, the most important thing, there was a question in the morning, whether we should do retrograde or antegrade. This will answer that question. The crown has to be advanced, and if you are able to advance the crown beyond the nodule, you do start with the retrograde burring and then you can do antegrade and retrograde. But if you're not able to advance, then most important thing which you have to do is that you have to make your guide catheter coaxial, push the nose cone inside, and this should constrain the crown. If your crown gets constrained, the game is over. Then you will be able to get inside and come out. If OA engages, yes, then you can, after the initial pass, you can do antegrade, retrograde. If the crown does not engage and it does not go in, please don't waste time. You will be dancing right on top of the nodule. You can damage the vessel, you can cause perforation. Get into either ROTA or laser and do this case. So the other thing which has been seen with the orbital is that it works best in the aortoosteal lesions. Within the coronary segment, if you have CTO segments, please don't attempt to do orbital atherectomy. It will kind of perforate because now the burr is rotating or orbiting in a confined area and it can cause perforation. So you should be very mindful of that. One such case, ostial RCA nodule. The guide catheter wasn't, if you see in this image, the guide catheter here is not coaxial at all. We made it coaxial. We pucked the nose cone, it constrained, and the orbital was done. And thereafter, after having done that, we stented the vessel with good results. Whenever you're dealing with calcium, you should use stents with good radial strength, and probably the best stent suited for calcific milieu is Megatron because it has the highest radial strength. Well, stent optimization in calcific nodule is equally important. And what have we seen over this? There are certain predictors of calcific nodules which tell you that your stent is not going to expand very well. These are patients who have greater circumference of the calcific nodule and there is a lot of surrounding calcium, there is negative remodeling, or you have with your tools not been able to fracture the calcium well. Stent expansion, as I shown you in the case example, is more symmetric with eruptive nodules. Malapposition is pretty common in calcific milieu. One should not chase this with aggressive balloon dilatations. You will have complications. So as stated, in a deformable nodule, you get good stent expansion. But if you have a protrusive nodule, you will not get good expansion and you should not chase it any further. Case examples on the OCT, this is a nodule which is jutting out. These are the stent struts. It lifts the stent struts and it doesn't let you oppose here. That doesn't mean that you take a larger balloon and start dilating. It will not happen. You should not do it. So similarly, some malapposition which is correctable, some is not correctable, you should accept. And there is enough literature. Yellow dots show you the calciums, and there is enough literature which tells you that stent edge dissections as well as incomplete stent appositions are very common with nodules. So you should accept them. Overall, patients with nodules, as I told you, that they have worse outcomes. The TLR rates are much higher. And if I have to compare between these two, or eruptive and non-eruptive, or protrusive or eruptive nodules have much worse outcomes. This is probably because there is enough literature to say that there is reprotrusion. Because these are at hinge point, these are broken small calcium fragments. They protrude through the stent struts. Then this happens within 6 months. There are a lot of case reports. And the other thing which can happen is that there can be small reprotrusion which gets calcified, or there can be recurrence which can happen. So overall, the eruptive nodules have much higher rates of target vessel failure compared to non-eruptive nodules. To summarize, I would say that there's need to identify these nodules. There's need to characterize whether they are deformable, non-deformable in the eruptive segments. Non-eruptive nodules are kind of stable. There are different tools which I showed you, case examples, which can be used for treating these nodules. Generally speaking, calcific nodules produce worse outcomes compared to those segments where there are no nodules. Amongst the two, the eruptive nodules are deformable, but they are notorious in terms of reprotrusion, so one has to be careful. The bottom line is treat the nodules only if there is an indication. So you have to keep the thresholds for treating nodules on the higher side. You shouldn't just go ahead and treat a nodule because it is present. You should treat it only if the patient is symptomatic and it's the reason for the symptoms. Imaging plays a very vital role. IVUS nurse holds an advantage over the OCT and IVUS. I showed you case example because it kind of tells you there is a lot of lipid pool behind. These are deformable nodules, or these are nodules which are early in their stage of pathogenesis. That means they have eggshell calcification. That means there is calcium on top, there is lipid core inside and calcium behind, and you can really deform these nodules. Well, you need a combination of tools to use in this setup. As I told you, eruptive nodules treatable, protrusive nodules are non-deformable, and they can cause stent under expansion. So please be very judicious in your approach towards these lesions. Thank you so much for your patient hearing.